Hey everybody, I'm Stuart Schlossman from MS Views and News. This is what we call the Compass MS Care program. We are sponsored tonight by Genentech, Sandoz, EMD Serono, TG Therapeutics, and Novartis. And each of these companies appreciate the work that we're doing in the United States, providing for those that need these programs most. Tonight's program, we have Caroline Conway, who's a speech-language therapist. Let's welcome Caroline Conway.
Thank you so much, everybody. I'm super excited to be here. Thank you to Stuart and the entire MS Views and News team. I'm super excited to be here with you all. I had an opportunity to work with Stuart and his team about 2 years ago and had such a great experience and made so many connections. So I was super pumped when he emailed me and asked me to come to this program. So thank you all so much for being here, both in person and online. So today I am going to be talking about speech pathology and the role in MS care. So I'm going to grab my little clicker here. Okay, and we're in business. So just a little bit of information about me. My name, again, is Caroline Conway, and I am a speech-language pathologist. I went to Ohio State for both my undergraduate degree and my graduate degree, so I was super pumped again to come back to Columbus. I moved back to Cincinnati after finishing my master's program, and I currently work at an inpatient rehabilitation hospital. My mom was diagnosed with MS in December of 2015, and this is really what jump-started my interest in this population. I think working clinically as well as having the personal connection really has shaped my role and passion for working with these individuals. And so for all of the survivors and care partners that are out there, I think the fact that you are here, the fact that you're asking questions, you're learning, you're advocating is so special and so important. So thank you again for being here. So before we kind of dive into speech pathology and MS, we have to first talk about what the heck is speech pathology in general. So when we talk about speech pathology, I think that the name is a little misleading. When you think about speech, you're thinking about talking. And that's true. I certainly play a role in helping people with their communicative functions, but speech-language pathology is a really comprehensive role. I think in a perfect world, we would be called head and neck therapists, because my job really is helping people with a variety of neurological concerns from the neck up. So I work not only with MS survivors, but with patients with a range of neurological changes on speech, so actually getting words out, making them sound clear and crisp. Language, so coming up with the right words to say and being able to understand language. Swallowing, which we'll talk about here in a minute, getting food down and making sure it goes where we want it to go. And cognition, which is a range of mental processes, things like memory, problem solving, processing speed, all that good stuff. So my interest in this field has really grown, especially now that I work at an inpatient rehabilitation hospital, all with adults, all with the neurological population, doing a range of treatments and evaluations. So tonight, we're really going to dive into what the speech pathologist does with MS patients. So I have a bunch of big words up here, which I promise we're going to explain and dive into, but this is a little bit of a roadmap for what we're going to be addressing tonight. So we're going to spend a little bit of time talking about dysphagia, which is swallowing impairment. Then we'll talk about dysarthria, which has to do with speech. And we'll round out the talk talking about cognition, which is, again, thinking. So first I want to talk about dysphagia. Okay, dysphagia is just the fancy medical term for difficulty swallowing. And dysphagia can look really different for everyone. When we think about dysphagia, we can really separate it out into two different parts. The oral part having to do with your mouth, and the pharyngeal part dealing with your throat. Okay, so when we eat and drink, as you all are enjoying your salads right now, a lot of things have to happen for things to go right when we eat and drink. And I think that this is a function that we often take for granted until we are maybe in a position where we are no longer able to do it efficiently. So, some oral symptoms of dysphagia. Maybe it takes you a really long time to chew because maybe the muscles in your lips, in your face, and your mouth are weaker than they used to be. Maybe your mouth is really dry, so after you chew and chew and chew, you just don't have enough saliva to get it down. Maybe after you chew and chew and chew, it's still sticking in your mouth and you have to take a bunch of drinks or swallow multiple times to get it down. These are all oral symptoms. They have to do with your mouth and how we receive food and get it down into our throat. Once we do all of that, we've chewed up our food, we've crunched it up, maybe we took a drink to wash it down with, then it has to actually go down into our throat and subsequently, eventually, reach our stomachs. In our throat, a lot of other things have to happen for us to swallow efficiently. We have to make sure that the food, we call it a bolus. That's just the fancy term for basically the mashed up food that gets down in your throat. I'm trying to keep this not as gross as possible. I know everybody's eating dinner, but the bolus has to get down into your throat in a timely manner. It has to not stick to all the muscles and mucous membranes. And then it has to go down into your stomach and not your lungs, okay? We call that aspiration. I'm sure we've all been in a position at some point in our life where maybe we're drinking something and it goes down the wrong way, right? We've all been there, okay? And our body's natural response to that is to start coughing and maybe our eyes start to water a little bit, but eventually we're able to get it out. Sometimes with MS, that's not the case. Sometimes with MS, whether it's a muscular or a sensory deficit, the food might start to go down the wrong way into the lungs, and the body might not sense it all the way. Maybe it starts to go down into the lungs and you don't even realize it. Or maybe it's going down into the lungs a lot and you're constantly coughing and mealtime is really effortful. Another thing that can happen with MS is potential for developing infection. That's kind of what we're kind of hinting at here. All of these things with dysphagia, both oral and pharyngeal, can potentially cause an infection, namely pneumonia. That's the big thing that we are on the lookout for, especially as many survivors are taking immunosuppressant drugs. Right? So if you're having food and drink getting down into your lungs where it's not supposed to go, and then you're on an immunosuppressant drug where your body is not able to fight off infection, you're at a higher risk of developing things like pneumonia. Swallowing is really complex. From the moment we take a bite to the time that it reaches our stomach, there's a lot of things that have to go right. But when things start to go wrong, it can be really problematic. So what we know about dysphagia in MS is that about 43% of MS survivors experience dysphagia. So nearly half of survivors are having this symptom, but I think it's not really talked about a lot. I think it's one of the things that people don't really know about until maybe it becomes a problem, until they're like, I just dread mealtime because it takes me forever to chew, or I don't want to go to restaurants anymore because I'm embarrassed that I'm coughing all the time. Safe swallowing is both socially important and medically necessary, and this is why we care. When we're talking about socially important, mealtime has a lot of cultural values for us as a society, right? A lot of the things that we do with family and friends are centered around mealtime. Hey, do you want to grab a coffee tomorrow morning? Would you like to go to that new bar down the street and grab some appetizers? How about the holidays, right, that are coming up right around the corner? Food holds a lot of social weight for us, and so it's important for us to be able to participate in this shared cultural experience. Not only is it socially important, but safe swallowing is medically necessary. we have to be able to meet our nutritional and hydrational needs by mouth in order to get by, right? If we are not meeting our nutritional and hydrational needs, we invite a host of medical problems into our lives that can really cascade and cause numerous difficulties. So what do we do about it? Right? That's the question. I've kind of given you the background. Again, dysphagia is just the word for abnormal swallowing. We know that nearly half of MS patients have difficulty swallowing. We care about it because it allows us to participate in shared cultural experiences, because it makes sure that we're getting our nutritional and hydrational needs. So what do we do? In terms of treatment of dysphagia and MS, first things first, we have to talk to our doctor, okay? Even though my entire job is dysphagia, well, among other things, but even though I, and the speech language pathologist, is considered the swallowing expert, I cannot do anything. I cannot see any of you until the doctor puts in an order. So you have to start with going to your doctor. And don't brush it under the rug. That is my biggest piece of advice. Obviously, again, every now and then we might all have something go down the wrong way, and that's going to happen. But if this is a problem that is chronic, if you are noticing for weeks on end, I just feel like something is stuck in my throat, or I'm coughing every time I'm drinking water, or especially I don't want to eat because it's so annoying, please, please, please reach out to your physician, because you can't come see me or anybody in my profession until the doctor puts in an order. So that's step number one. Step number two is we have to do a swallow study. We have to see exactly what is going on in there. And unfortunately, I don't yet have X-ray vision. I'm working on it, but I don't have it yet. So we have to do an imaging study, okay? So as you can see in my fancy little video here, this is one of two swallow studies that we can do. This is a snapshot from something called a modified barium swallow study. We call it an MBS. So a modified barium swallow study is basically a test where you go into an X-ray suite and we feed you things of different consistencies that have barium in them. Barium is just a dye that basically makes it show up on the X-ray. So you eat and drink things and we see what is going on. Are things going the right way down into your stomach? Are they going the wrong way down into your lungs? Are they getting stuck? Where are they getting stuck? Why are they getting stuck? And this gives us the information that we need to make decisions about your care. The other type of test that we do is something called a FEES, F-E-E-S. It stands for fiber optic endoscopic evaluation of swallowing. This is where we put a scope through your nose and pass it transnasally, so it gives us a bird's eye view of your swallowing. And same thing, you just eat and drink things, and then we review it and we talk about it. So again, you got to talk to your doctor so they can send you to me, and then I can look and see what's going on, and then we can treat it. Okay? So treatment is kind of really broken down into two main categories: strategies and modified diet. When we talk about strategies, okay, we're talking about what can you do at mealtime to make your life easier. So maybe you need to be taking smaller bites. Maybe you're known to shovel in, grandma's favorite casserole, and that's why it's getting stuck, is because you're just taking too big of bites. Maybe you need a liquid rinse. Maybe we need to be more intentional about taking drinks after our bites. Maybe we need to do something called an effortful swallow, where we're squeezing our swallow muscles. There's also a lot of exercises. I could bore you by talking about the Masako maneuver and the supraglottic swallow and all these crazy things. But the bottom line is that there are both exercises, things that we would teach you, that you would come to therapy to learn to strengthen the muscles, and there are strategies, things that you can do at mealtime, again, that we would teach you to help you be more successful with your swallowing. The other thing you can look into, or we would advise you on, is a modified diet. So what you're all eating right now is a regular texture diet. Everybody here has a salad and, iced tea or water, which is considered a regular normal diet. But there's different diet textures. So regular texture is kind of the most normal, so to speak. Then we can look at something called soft and bite-sized. So maybe you have softer foods. Maybe that makes it go down easier. Maybe you need some things that are pureed or more of a minced texture. We, as your therapist, after doing an instrumental swallow test, the x-ray that I showed you, would make decisions collaboratively with you and your family about food preparation if necessary. The bottom line is that there are a lot of things that can be done about swallow impairment. And the first step is identification. Please don't brush this under the rug, because what happens is that I have patients come to me way too late in the game when they've stopped enjoying their favorite dinners and they don't want to go to restaurants anymore because they're embarrassed. And it really breaks my heart because they didn't know that speech therapy exists. They didn't know that there were options, that there were things that they could do to help strengthen their swallow muscles. Oftentimes this is due to spasticity in the swallow musculature, okay? Just like you might have spasticity in your arms or legs, okay? Same thing can happen in all of these muscles in your throat. It can also be due to sensory changes. So maybe the muscles that are supposed to sense things going down the wrong way are not doing their job anymore. We can fix that. There's a lot of things out there, so please reach out to your physician if you have any questions. All right, next up, we're gonna talk about dysarthria. So dysarthria is a motor speech disorder, or a group of motor speech disorders, really, that have to do with a variety of different changes to your speech mechanism. So respiration, just the fancy word for breathing. We can't talk if we can't breathe, okay? All of our power for speech comes from our lungs. If your lungs are not able to inflate and coordinate how to get the air up to your vocal cords, your voice is going to sound really quiet and really breathy. Okay? That's a huge problem we see with MS survivors, is that they don't have the power anymore to be able to be heard. Phonation, fancy word for your vocal cords beating together. Spasticity in the vocal cords is one of the most common things that we see in this population. I'm sure some of you have watched videos of different professionals that have MS, or maybe you yourself feel like your voice doesn't sound the same that it used to. Maybe it has a different quality to it, and we'll talk about what that sounds like in a minute. But your vocal cords can beat together in a different pattern, which changes the way that you sound. Articulation, how crisp and clear your voice sounds. If you don't have the sensation or the muscular strength in your lips, your face, your cheeks, all the parts that help us make our speech sounds, it might sound a little slurred, or it might be a little slushy. And then prosody. Prosody is just the fancy word for how smooth and natural our speech sounds, right? If I am really excited, I might talk really quickly because I'm so excited about this thing that's happening. But if I'm sad, I might be like this, and I'm not feeling it. That's because of prosody. That's because I can change how my speech sounds based on how I'm feeling or what I want to convey. But sometimes in MS, people have a more monotone way of speaking, and that's because of dysarthria. So I kind of gave the examples of the symptoms up on the board here. Again, we can also see a vocal tremor. That can happen as well. We talked about the lip and tongue jaw movements. Decreased intelligibility. That's usually the biggest thing. Intelligibility really just means how well can somebody else understand you. If you are talking to somebody in the community, do they know what you're saying? And maybe your family member who spends 24 hours a day with you can kind of translate or decode what you're saying. But if you're talking to the cashier at Kroger, they might not know what you're saying, right? So we want you to be able to have access to speaking to all the people in your community that you want to be able to speak to. And that's where speech pathology comes in. So we know that anywhere from 35 to 51% of people with MS have dysarthria. So again, it could be up to half of survivors are having these symptoms. I think, again, these are all things that we just don't really think about when we think about MS, but it's happening. We know that there's different types of dysarthria, and I'm not going to bore you with all of the details and all of the, diagrams I was forced to remember in graduate school, but I will tell you that the two most common types of dysarthria in MS are spastic and ataxic. So, we all heard the term spasticity, right? That's not news to anybody here. Spasticity can happen in the vocal cords, like we talked about, and it can create what we call a strained, strangled vocal quality. It's really hard to imitate, so I'm not going to do it, but you guys have all probably heard or maybe can imagine. It sounds really tight. It feels like there's something gripping. This can often happen in individuals who also have spasticity elsewhere in their bodies. It tends to kind of co-occur. But it can be uncomfortable and it can be frustrating because it can be pretty obvious. It can be embarrassing. And that's where that psychosocial aspect comes in. We talked about dysphagia and how food is socially important. Communication is also socially important, right? That's how we, share in special moments with people. That's how we tell them good news. That's how we comfort people. We communicate, right? If we're not able to communicate in a way that feels natural to us, it can be really frustrating. Ataxic dysarthria is a little different. This usually has to do primarily with lesions in the cerebellum, which is we call it like the little brain. It's this kind of little guy that sits right below the main part of the brain. And it's important for being able to make like online corrections to your speech. So in the moment, being able to correct yourself and being able to make your speech nice and smooth. People with ataxic dysarthria have that quality of drunken speech, okay, where you kind of sound slurred, maybe it's a little slushy, kind of like you've had one too many and you're stumbling home at the end of the night. But if you're an MS survivor, it might be 9 a.m. and you just woke up, but your speech doesn't sound right. Okay? These are the two most common types that we see in our MS survivors. When we talk about treatment, there's a number of different things that we can do. However, most of them tend to be compensatory. When we talk about compensatory measures, we're talking about things that you as the survivor can do to help make your speech better. It's not necessarily restorative, and I will be very upfront about that. All the speech therapy in the world is not necessarily going to change the fact that you might have lesions in your cerebellum or in your brainstem or in your cerebrum. I cannot change that, but I can give you tips and tricks for how to make your speech more intelligible. So 3 main things: breath support. Breath support, breath support, breath support. This is something that I run into with my survivors all the time. I have so many MS survivors that have decreased breath support for a variety of reasons. Partially because of the actual nature of their disease progression. Sometimes it's a little bit of deconditioning. Maybe they're not as mobile as they used to be. And so maybe their breath support is not as good. Maybe they're not sitting up as much. Maybe it's a postural thing. Maybe they're hunched over all day, so they're not used to getting their lungs to inflate, to give them that power behind their speech. I do a lot of training on breath support with my MS survivors. There's also some different devices and things you can buy. Again, I'm not going to go into super detail, but there are things out there that exist to basically help you retrain your muscles. There is something called an expiratory muscle strength trainer. We call it an EMST. It's a little device about this big, and it's something you blow into, similar to a spirometer, if you're familiar with those. And I use those in my practice a lot. Again, we talked about how volume comes from your lungs, okay? If you're talking really quiet like this, you don't have any power in your lungs, okay? We need to get that power back. So I need to train your exhalation muscles and get them stronger. We also need to talk about our speaking rate. My MS survivors love to talk a mile a minute when nobody knows what they're saying. So that's one thing that I talk to my survivors about all the time. Slow down. It's frustrating because it feels awkward and it feels weird. And you're like, why do I feel like I'm talking like a snail? But I promise It makes a difference to that cashier at Kroger who has never met you before and has trouble understanding you in a loud and noisy environment. A lot of what speech therapy is retraining your brain to be aware of the deficits that you have and teaching you strategies for how to compensate for them. I've used things like pacing boards, where I have a little board for the patient and they have to tap a circle when they say each word to force them to slow down. And you'd be surprised how many want to just zip right through all the circles. And I'm like, nope, you got to go one at a time. That is really like maximal support. Obviously, my goal is to make it as natural as possible. My goal would be that you're out in the community conversing with anybody that you would like to and that they understand you without any tools. But sometimes we need tools, and that's okay. And I think learning about the tools and implementing them as needed is the biggest piece of the puzzle. The last thing is augmentative and alternative communication. We call this AAC. Augmentative and alternative communication is any modes of communication that are not verbal. Anytime you send a text message, that's AAC. Anytime you talk with your hands, that's AAC. Anytime you give somebody a wink, that's AAC. We all do this all the time. We are constantly communicating things in nonverbal ways. I will say that AAC, when we think of it in traditional terms, looks like using communication boards. If anybody has ever seen maybe a child with autism that uses an iPad to communicate, that's another population that this is really common. AAC is relatively uncommon in traditional methods. I'm not talking about text messages, but communication boards, iPads, things like that is relatively uncommon for the MS population. However, I have seen survivors who have really, really significant spasticity in their vocal folds such that they are really not able to make contact. They're not able to phonate and get their vocal cords to beat together, so they use a communication board. And so my job is to train them and to program it so they can tap on things and it will talk for them, which is really, really cool. All right, last but not least, and maybe my favorite thing to talk about is cognition. So cognition is a range of mental processes involved in everyday functioning. That's kind of the easiest way to break it down. But cognition is just the fancy word for thinking. We are all using our cognitive skills every day, from the moment we wake up and have to go to the bathroom and brush our teeth, to when we make lunch, to when we go for a walk after dinner with our friends or family. We are all using these cognitive processes to varying degrees. Okay, things like memory, recalling that you need to go to the doctor next Tuesday at 10 a.m. Problem solving. Okay, my fire alarm is going off. What should I do about it? Information processing, taking in new information. If you go to the doctor and you're having a conversation with them, can you process what they're saying, or is it completely over your head? How do we take in new information? Can we pay attention? If Dr. Boster's going on for, 25 minutes and you're like, I can't pay attention to this guy anymore, that's a problem, right? We got to be tuned in. What are our strategies for that? Okay, and word finding, making sure we can come up with the right words to say, which we'll talk about more in a second. So cognitive changes are a very, very common symptom of MS. The research tells us that cognitive changes are weakly related to physical disease progression. There's some research on that that's kind of up and coming, but we know that cognition is often affected because fatigue is a common symptom. And there's, plenty of research, and I'm sure everybody in the room could raise their hand and say, yeah, I have fatigue with my MS. So when we talk about fatigue, we're often talking about physical fatigue, and which is a very real thing, and I'm not minimizing that in the slightest. However, cognitive fatigue is also a very real thing. Has anyone's brain ever felt really tired at the end of a long day? Show of hands, yes, I'm seeing lots of hands, lots of head nods, right? This can happen at any time in the disease progression, but early recognition is key. Similar to dysarthria, similar to dysphagia, I cannot do anything if you don't tell your doctor. So please, 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 if you are noticing, man, I just can't get through the day. By 2 p.m., my brain is fried and I just can't remember anything. Or, I'm having a really hard time coming up with the right words to say. Like these words are on the tip of my tongue, but I just can't formulate my thoughts. Or yikes, it's the third day in a row I forgot to take my medication. Uh-oh. Please tell your doctor, because there's things that we can do. There's therapies that we can look into, and we're going to talk about those a little bit right now. So when we talk about treatment of cognitive dysfunction in MS, there's kind of two main things here. The first one is pharmacologic treatments, which I'm not really going to talk about. Number one, it's not my specialty. And number two, there's honestly not a ton out there specifically related to like taking drugs for your memory. Like if you guys have all seen those like Prevagen commercials, don't get me started, okay? So there's not a lot out there for specifically like a magical pill that's going to help you remember to take your medicine. There are medications out there, and I'm sure Dr. Boster can talk about this, for like neurostimulants, for things for fatigue, and that does play a big role. And I'll let him talk more about that because I'm a big proponent of you have to be awake to be able to remember. Okay, so we have to get fatigue in check first before we can work on our higher level cognitive processes. So I'll leave it to him to talk about that, but knowing that there are things out there from a pharmacologic standpoint. However, what I'm going to talk more specifically about is compensatory strategies, which has been a theme across the night, right? There's things that we can do to help you compensate for these changes that you're having. So, couple of things. When we talk about compensatory strategies, we have both internal strategies and external strategies. Internal strategies are things that you do in your brain to help you be more successful. I'm going to talk more about those on the next slide, but those are things like repeating information in your head or, making an association. We'll talk about it. This slide talks a little bit more about external strategies. Things outside of you, things in the environment that you can do to help you recall information or be more successful with your thinking skills. So this is not rocket science, but this is a real thing that we do in our practice and have real conversations with survivors about to help them be more successful in getting through their day. Having calendars, both on paper or on your phone, whatever works for you. I know you all are very busy with numerous doctor's appointments and therapies and different things going on, but we have to be able to have something to refer back to, okay? We cannot trust that it's all up here. I don't have it all up here, and I literally work on cognition for a living, okay? I use my compensatory strategies constantly, okay? We have to start to understand that MS is a autoimmune neurodegenerative condition, right? And while speech therapy is not going to regrow nerve cells, it is not going to throw back some myelin onto your nerve cells, there are things with repeated practice that we can do to help your brain be more successful. Using calendars, setting reminders. I am the biggest proponent of the iPhone reminder app. If you don't know what it is, hit me up. Other things, removing distractions. This is huge. I think that we live in a world where it is go, go, go. It's loud, it's fast. There's an expectation that we are doing and going all the time. And that's not realistic for everyone in general, but especially people with MS. We have to slow down and remove distractions, especially when we are trying to engage in a cognitive task. And when I say a cognitive task, I could mean as anything as sitting down, with your kids talking about the plans for Thanksgiving, all right? Whose house are we going to? When are we getting there? Who's bringing the turkey, right? Or maybe it's a little more complex. Maybe it's going to a doctor's appointment and, you're having some hard conversations with your physician. You want to set yourself up for success. Make sure that you have a plan, okay? I have my notepad ready. I also have my phone. I'm going to record using voice memo. I've removed the distractions, okay? And if necessary, I'm going to take a break. That cognitive fatigue thing that we talked about is very real. You have to know your limits. You have to be able to take a step back and say, this is too much for me right now. Can we try this again later? This whole Thanksgiving shtick, I can't do it with Aunt Susie right now. Can we do this later? Okay, she's overwhelming me. And advocating for yourself. If you take nothing else away from this talk tonight, I want it to be this. No one knows your body like you do, and no one is going to do anything about it except for you. You all have excellent care partners that are here with you, and you should be, so lucky to have, sisters, wives, husbands, cousins, whoever is here with you, and that's so excellent. But they don't know unless you tell them. Taking a brain break sometimes is the best thing that you can do. It can be hard to say, hey, I'm really tired right now. I need to go lay down. Or can we talk about this tomorrow? I'm just really exhausted. But you're putting yourself in a better position, in a position to be more successful because you are recognizing that you're getting tired, you're recognizing that you're overstimulated, and putting yourself in a position to do better the next day. The last thing that I leave you with is this little acronym that I love, and this is WRAP. So this is a specific memory technique, and this is one of the easiest things that you can implement just in your daily life to help you be successful with recalling information. So write it down. I see many of you with your notepads today, which is excellent, okay? We know with MS, and again, people without MS, we can't always trust our brains, and that's okay. That's why we have pen and paper. Number one, it allows us to create a mind-body connection when we're actually writing something down. Research tells us that when we write things down, we're more likely to remember them, and even if we don't remember them the first time, we can go back and look at that paper. Repeat it. Repeat information in your mind. Go over it, okay? If you're preparing for a doctor's appointment and you have like 3 things that you want to make sure you don't forget, repeat them in your head on the car ride over. Okay, I need to talk about my spasticity, my incontinence, and my word-finding deficits. Spasticity, incontinence, word-finding. Spasticity, incontinence, word-finding, right? Repeat it over and over in your head. Have it in multiple places. You have it written down. Now we're repeating it in the car ride over. Oh, can we associate it? Can we take this new information and connect it with something that is familiar to us? So, if you have incontinence, well, that was probably something you're not going to forget, right? Okay, so maybe you had an experience where you were running errands at Target and had an incontinence episode, okay? Thinking about that information and connecting it to a familiar experience, something that was a lived experience that you had so that it sticks in your mind a little better. Or, if you meet somebody for the first time and they say, hey, my name is Joe, and you're like, oh my gosh, my son's name is Joe. Well, we just made a connection, right? We just associated this unfamiliar person with somebody who is a loved one, and it's going to stick better. Lastly, picture it in your head. We want to make sure that we are creating this visualization, thinking about how can we take new information or old information and create a visual. If you're making a grocery list, thinking about my local supermarket, how do I weave throughout the aisles so that I can get, my fruits and veggies, my deli, my, meats, etc. Picturing things in your head. This is such an easy little acronym, but I think it really packs a punch when it comes to recalling information. All right, I have some references here. I promise I didn't make everything up. But I really appreciate you guys listening. Thank you so much. I'm thrilled to take some questions. And thank you again for being here and listening.
Thank you very much, Caroline. All right, I'm going to take some questions from the field, and then I'm going to take some questions that came in online, and then I'll go back to the field, and we'll see who's here. Okay, I hold the mic.
That's fine. I have a problem with constantly clearing my throat, and I'll have some days when it's good and other days when it's bad, and by the end of the night, my throat is so sore, and I also have the problems with I'll cough, and I can't stop. Is that the dysphagia? I mean,
Yeah, thank you for your question, and I appreciate you bringing that up. Yes. The short answer is yes. I would talk to your physician about that. So even things like that, that's enough to make you, come to something like this and ask that question, right? It's enough for you to be like, my throat is sore and I'm uncomfortable. And, it sounds like, that is bringing discomfort to you. I would bring that up to your physician. That is usually kind of how it starts, and it can progress, or there can be, things that we can do to step in. There are certain therapists that specialize in like cough suppression therapy. I'm not one of them. I will be fully transparent. But there are speech language pathologists that treat cough specifically. So there are things that you can do for that cough or like that throat clearing. And what I would be curious to know, and what the x-ray test would do, is help identify, why are you clearing your throat so much, right? Is it because there's food residue stuck in there? Is it because you have inflammation? What is the cause of this? And that is where we will kind of start the process, and then your therapist and physician would work with you to kind of figure out a game plan. Yeah, good question.
Next question is back here.
Are you familiar with, or have you heard of people aspirating while under anesthesia?
That's a good question. And I will be very honest, I don't know a ton about that. But what I will tell you is we all aspirate every day. So the likelihood that somebody is aspirating under anesthesia is very high, because I probably aspirated in my sleep last night. And so when you're under anesthesia, obviously, you're not in a conscious, wakeful state. So that can definitely happen. And I mean, I could go on a whole rant about this. So we all aspirate all the time. Aspiration is just the fancy word for things going down into your lungs. It gets really hyped up. We, as a society, are really scared of aspiration, but it is okay. If you aspirate under anesthesia, everything is going to be fine.
They're treating me like it's allergies, but it's really not allergies.
I'm glad you brought that up. That's actually, I was going to say something about that when you initially asked the first part of the question. And I was curious, and we could, sidebar about this, but that is probably what they're going to do. And I'm not saying that they're wrong. And I don't know. Again, we have to really get in there and see. But I would push. That's where that self-advocacy piece comes in that I was talking about. You know your body better than anybody else. If you've taken, Zyrtec and you're doing the Flonase and it's not getting better, well, it's probably not allergies. Push and see what else is going on, because we have to get to the root cause of the problem. I'm a big fan of figuring out the underlying issue rather than just slapping a bunch of Band-Aids on it.
Next question's here.
Several years ago when I was in the hospital, I was in a coma and I came out and they had done the trach thing, and they said, okay, now you got to go through swallowing therapy and all the tests and all that fun stuff. Is that something that I get to look forward to later in life? Is there like residual effects from that, or?
So are you asking, like, is the tracheal intubation going to impact you long term, or are you asking, could you potentially have swallow deficits as a result of your MS later in life?
The first one.
The first one.
Yeah.
No, you will not have residual swallow deficits. I will say, and again, this nothing is ever 100% or 0%. There is a small percentage of the population that can have swallow deficits. Do you have swallow problems now?
Not really. I have more the memory thing.
Okay, gotcha. Then you could have swallow problems as a result of MS separately from the tracheal intubation. But tracheal intubation, swallow impairment, which is a very real thing, and I'm glad you brought it up, really only lasts for about a week. Yeah, so that's not going to come back and bite you in the butt later down the line.
Cool. That way I know if something happens, it is the MS.
Yes, exactly. Good question.
Any other questions out here? If not, I'm going to the laptop. All right, but on the way, somebody asked me if they had, they were told that they have spasticity in their vocal cords by a doctor. What treatment could there be for that?
That's a good question. So a lot of our therapy from a speech therapy standpoint is going to look at like relaxation techniques and teaching you. There's some things called like easy onset and light articulatory contact, which are basically treatment methods for spasticity. And they're also treatment methods for stuttering, coincidentally. And again, I'm not going to get into super detail on that. There's also, from a medical standpoint, things that they would do, like Botox injections and all of that, which I certainly am not qualified to do. But there are speech therapy interventions for that, of trying to reduce the tension. There's also therapists that are trained in something called manual therapy, where they do like massage, and there are ways that you can try to reduce the tension in your vocal folds. Again, I'm not trained in that, but there's a whole subset of speech language pathologists that are trained in manual release therapy.
Great, thank you. From online, this just like 5 or 6 questions. First one, I drink and eat and feel like I'm choking. I don't know how to prevent it from happening. It's consistent but not constant. Can you tell me what I can possibly do?
Talk to your doctor. Yes. So that is exactly what I'm talking about. So those are the types of things where first step, you have to reach out to your physician. So you mentioned, how do I prevent this, or what do I do in the moment? Things you can do between now and when you get an appointment with your neurologist would be small bites. Okay, we always, if you are aspirating, meaning things going down into the lungs, we would much rather it be a small volume of aspiration than a large volume. So small bites, small sips, and going slow. Which kind of comes with a small bite and small sip thing. Again, you're more likely to aspirate when you're chugging your Mountain Dew than taking a small sip of it. So slow rate, small bites, small sips. The other thing is after. So let's say you take your small sip of your Mountain Dew, you're still coughing, or let's say you take this small sip and it doesn't quite feel right. Your body should cough. That is the natural sensory response. Coughing is not going to hurt you to a degree. If you're just coughing to cough, like that's, obviously not good for your body. But if you are consistently experiencing symptoms of aspiration, the primary sensory response is to cough and then re-swallow. So take a drink, cough, re-swallow. You're probably good. However, I definitely encourage you to reach out to your physician because they will get you. So they have to put what's called like an order in, or a referral for you to come get speech therapy. And then we would do the instrumental evaluation, let the x-ray test, or the one where we put the scope through your nose and then come up with a plan with you.
Thank you. Next one says choking on saliva out of nowhere, not from eating or drinking. What could that be caused from?
That could also be an MS symptom. That is true. That's a little trickier to treat. I would ask, and I know we're not going to have a back and forth conversation, but my next question would be, how is your secretion management? Again, I know this is not a great dinner time topic, but secretion management meaning, is your body overproducing saliva? Because those types of situations can cause to increased risk of aspiration, just because your body might not be prepared to kind of deal with that degree of secretions. But I would encourage you to do more of an effortful swallow. So when you go to swallow that saliva, try to think about swallowing hard. So these muscles here, pretending like you have a golf ball stuck in your throat and really swallow hard, because what that does is it adds an extra layer of protection to your airway, such that it is more likely, the saliva is more likely to go down into your throat, or your esophagus, rather than into your lungs. It's not foolproof, but it's something.
Thank you. Next one. How does hearing or a lack of hearing play into the whole speech cognition subject?
Wow, asking the good questions. Oh, I could talk about that all night. Okay, so hearing is super interesting because hearing has to happen really before any of this other stuff. Not the dysphagia in dysarthria as much, but the cognitive piece of things. In order to remember something, first we have to be awake and alert, and then we also have to hear it. And then we go up what's called the cognitive hierarchy. So if you have hearing deficits, that can play a profound role in memory and cognitive impairments. We know that people with hearing loss are significantly more likely to develop Alzheimer's and dementia. And so for people that already have MS, it's kind of the same deal. If you're not hearing information, not only are you not going to remember it and process it, but you're also missing out on a lot of stuff, which is just cognitive stimulation. Kind of this idea of use it or lose it, right? If you're in bed for, 2 months and you don't get up, your arms and legs are going to be really weak. Same thing with your brain. If your brain is not being stimulated by hearing information as well as environmental noise, it's not getting that constant input and it's going to get weaker. So you're going to have more cognitive deficits. That's a great point. Go see your friendly neighborhood audiologist.
Okay, thank you. Another one writes, how does Medicare treat speech language therapy?
Wow, another hard hitter. But poorly. That is a whole big rabbit hole. I wish I had more positive things to say. Honestly, and I cannot really speak too much about just outpatient therapy. I am an inpatient therapist. I work at a hospital full time. So my patients specifically, what happens is they come to me and they see me every single day at a hospital for anywhere from 45 to 90 minutes. And it is covered at 100% by Medicare and Medicaid. Then they go home and they get home health services, which is covered a good portion by Medicare or Medicaid. Then they go to outpatient, which is likely what you all would be receiving, and that's where I don't really know. And that's not helpful, and I recognize that. What I understand, and again, this is all from my patient's perspective, so patients that were acutely ill, were in a hospital, and then discharged home, are receiving about 6 hours a week of therapy split between physical, occupational, and speech therapy, and that is covered by Medicare and Medicaid. However, they only get a certain amount of visits. Some insurances do it where you get kind of a bucket of visits. So maybe you have 20 visits in your bucket split between PT, OT, and speech. And maybe you have a lot of speech needs. So maybe you want 10 of those visits to be just speech and the other are going to go 5 and 5. Some insurances say, cool, play it however you want. Some insurances say, we don't care. You're going to get 5, 5, and 5 or whatever. Okay. If you're just trying to go get speech therapy, I don't have a great answer, but I will say my professional organization, the American Speech and Hearing Association that I'm licensed through, is working very, very hard with CMS, the Centers for Medicare and Medicaid, to basically increase our billing such that we are reimbursed higher for the services we provide. Obviously, I'm biased and I think the work that we do is great, but insurance is the worst, is the bottom line.
Thank you. Next one. Can someone be initially pre-diagnosed with multiple sclerosis based solely on how fast they speak?
I would not say that. I would not say you cannot be diagnosed with MS based on how fast you speak. You have to be diagnosed with MS, you have to have an MRI, you have to have proof of lesion. So you have to have, most people go through a spinal tap and you have to get an MRI. So I, as a clinician, absolutely cannot diagnose MS, I cannot diagnose MS in and of itself as a clinician by myself. However, and this has happened actually kind of recently at my hospital, we had a gentleman who had all the signs and symptoms of MS, and I was working with him, and he had been at another hospital, yada, yada, and I went to my physician, and I was like, hey, I really think you need to send this guy out for a spinal tap and an MRI. I really think he has MS because of XYZ, and he did. So, again, I did not diagnose that. This imaging diagnosed that, but I had a hand in recognizing the signs and symptoms. But rate of speech is not a qualifying symptom for MS diagnosis, no.
Okay, thank you. Anybody in the audience? Any questions? Then let's thank Caroline for coming here today.
Thank you so much. I really appreciate it.
So again, we provide these for a reason. We want people to learn. This is a great audience tonight. I hope to see you all again next year, because it won't be 2024, but it will be 2025 when we do see you again. And so I want to thank you all for being here tonight. Aloha. Thank you. Be well. Bye.